My name is Robbie Robinson, and I'm going to introduce the next presenter. But before I do that, I'm going to also tell you why I'm doing the little bit that I'm doing in terms of coming to these summits and participating with Finn as a survivor. I'm doing it because I feel like it adds to my longevity. I was originally diagnosed with prostate cancer in 2002, and basically I have a PSA done about twice a year, and it's been less than 0.1, so I feel pretty good about that. That being said, I also know that there's a real need for research in terms of the clinical trials and things. And I'm going to introduce you to a gentleman, a doctor, which is Dr. Ahar Goto, who's an Associate Dean of Clinical Affairs, Chief of Urology at Howard University Health Science Enterprise. And he's going to tell us how we can look at working that challenge out around clinical trials. Let's put our hands together for him.
Great. Thank you, Robbie, for the introduction. And it really is a pleasure and a privilege to be here. This is, I think, my third or fourth year participating in this wonderful event. And every year it's the same feeling I have. I really do feel privileged to be among this audience of researchers and clinicians and legislators and advocates, and most importantly, prostate cancer warriors, right? I like that terminology. I also want to take this opportunity to put a plug in for Tom Farrington. Tom is, as all of us know, a remarkable man. And, I've had the pleasure of getting to know him over the last few years. And, one of the things I have to say is that I really have adopted him as a model of leadership. When we talk about, implementing programs, one of the biggest challenges in implementation is sustainability. And as you can see, this program is a sustainable program and doing remarkable things both locally as well as nationally. And so it's really been a privilege getting to know you, Tom. So I wanted to put that plug in for you. Yeah, and then also before I get started, I want to reassure you that I am, as a speaker, well aware of the fact that I'm the only thing between the audience and a delicious lunch. So I'm going to try to move this thing quickly. We've got a few slides, but what I'm going to try to do is, any type of material that we've already gone over, I'll just kind of slide right through that and then focus on what I think are some of the salient points that may not have been touched so far in this very, very informative session. Next slide. So, of course, we've talked about the incidence and mortality associated with prostate cancer. I won't spend any time on that. I will say that it's important to reemphasize some of the issues and controversies that researchers have to continue to keep their eye on as we try to address some of the issues related to prostate cancer. Certainly, how do we screen, who we screen, how often do we screen, what is the best modality, I think is an important question. But also, how do we treat? And risk stratification obviously is an important part of that. How do we make that diagnosis? How do we identify those folks who are more likely to suffer from the disease as opposed to those folks who just were incidentally diagnosed with the disease with no long-term impact? All of those factors are very critical in our research efforts. Next slide. Prostate cancer is a global health problem. I think Compton touched on this earlier in the morning. I love this graphic that shows the distribution of incidence and mortality. The darker images on the left in blue are the incidence distribution, and you can see that the incidence of prostate cancer is much higher in the Western Hemisphere. But then when you go over to the other picture with the orange, the distribution of mortality is more significant in sub-Saharan Africa as well as in the Caribbean. And so you can see that there clearly is disparity in incidence, but more importantly, mortality. Next slide. And then bringing it back to home, prostate cancer is a very prevalent disease. Not only is it prevalent, it is a lethal disease, or it can be a lethal disease. Again, not only because of the fact that we diagnose prostate cancer more than any other cancer in the United States, but also because of its high mortality rate, second only to lung cancer. Next slide. So as we begin to now decide how are we going to study, what types of issues are we going to study, the best way to do it is, first of all, what do we know about prostate cancer? What are the things that we're pretty confident that we have a good understanding of? You can, I think, hit that, and does it? Okay, so just keep going until we get to the fourth button. There we go. So it's a common diagnosis in elderly men. We know about certain risk factors, family history, we've talked about that, ethnicity, dietary factors. Someone also mentioned that in the early stages of prostate cancer, there are no symptoms. That's very important to understand. And then the last is that the probability of cure is highest in the earliest stages of the disease. Next. Oh, and then, of course, most men with prostate cancer do not actually die of prostate cancer. And that's the big prostate cancer screening conundrum, that we can go out and identify this disease, but the question is, how do we stratify out those men who are most likely to succumb from the disease? And we've already heard about some of the technical advances that are emerging. Next. So what don't we know about prostate cancer? Next. So trying to understand, again, how do we predict disease-specific mortality? Next. What is the optimal treatment? There really have not been any very well-designed prospective studies comparing all of the very commonly used modalities for treating prostate cancer. And then what is the role of genetics and environment in the natural history of the disease? How do these two factors play a role in deciding how that disease is going to play out in an individual? And then finally, the long-term impact of early detection strategies. New slide. Next slide. Yeah. So finding prostate cancer early is not enough. And this is a great illustration of the impact of what's described in the research literature as lead time bias. So if you identify a disease earlier in the natural history of the disease, it doesn't necessarily mean that that's going to have any impact on that person's survival. So in this first scenario, you can see an individual who wasn't screened and ended up having the diagnosis of cancer and then eventually succumbing to the disease. In the second scenario, you have someone who was screened and therefore identified earlier, but if you look at their overall life expectancy, it's the same as scenario one. So although you've identified the disease earlier, you really haven't had any impact on survival. And then the holy grail of early detection is really to be able to identify the disease at an earlier point in its evolution and be able to cause it to prolong life expectancy. So that life extension is what we really want to aspire to when we're talking about early detection. New slide. So I think Dr. Deans presented some data on, actually this is a different study. This is a European randomized prostate cancer screening cohort, the same cohort that we looked at when we, the U.S. Preventative Services Task Force used some of that data to come up with their conclusions. So a small group within that cohort looked at the impact of radical prostatectomy versus no treatment at all. And their conclusions was that there was a substantial impact on reducing mortality. But if you go to the next slide, this was the study that Dr. Deans talked about, and I won't go into details, but the PIVOT trial, which was done in the United States, pretty much did the same thing. They compared radical prostatectomy to observation, and their results were very different. They saw no differences in survival. So you can see that here we have some conflicting data that's coming out, and this is part of the conundrum. Next slide. So when we talk about screening specifically and the decision to screen, the U.S. Preventative Services Task Force and many of the regulatory and decision-making groups have used these two studies, the PLCO study as well as the European Randomized Prostate Cancer Screening Trial, to base their recommendations not to screen. And I won't go into details, but as you know, both of these studies have conflicting data as well. Next slide. The PLCO showed that there was no significant survival advantage if you screened men versus you didn't screen men, even though there is a subgroup that did show some differences. But the bottom line is that this particular study had a number of flaws related to contamination, study design, and so that has been raised. But most importantly, next, the African American accrual rate was very low, almost just under 5%. Next slide. On the other hand, the European Randomized Prostate Cancer Screening Trial, again, a very large multi-center trial looking at the impact of screening, showed that there was about a 20% reduction in mortality if you screened individuals in that group. And so again, we have this situation where we have conflicting data. Next. And again, in this particular study, there was a very, very low accrual of men of African descent. Next. So when we talk about the decision to screen or not to screen, one of the big arguments is, what are the benefits versus what are the harms? And the way that most of these groups have come to this conclusion is by bringing together a number of different studies, some of which looking at the benefits and some of which looking at the harms. But the problem is that the quality of those studies in those two categories are very different. For example, the study designs in general for the studies that looked at the benefits really were not the highest quality study designs that one would expect, whereas in the studies that showed harm, you see that those were much better designed studies. And so it's almost like comparing apples and oranges, if you will. But that is one of the challenges with the recommendations that are coming out. They're flawed in their thought process of how to make these comparisons. Next slide. And so at the end of the day, who is it that really is impacted by this statistical conundrum? It's the men who are diagnosed and sometimes, unfortunately, die of prostate cancer. And so we really have to keep that in the forefront, that as we try to sift through all of this research methodology challenge, these outcomes challenges, at the end of the day, we have to remember that there's that patient that's right in front of us, and we have to work with that patient to really come up with the best approach to screening and treating those individuals. Next. You've seen this graph earlier showing the disparity in the risk of developing prostate cancer by ethnicity. African American men are more likely to be diagnosed with prostate cancer. Next slide. And you also saw the mortality data as well, showing a much higher mortality rate, even though the mortality rate is decreasing. And we believe that part of that is due to better treatment and possibly also early detection strategies as well. So this is an interesting study that Ike Powell up in Detroit published a couple years ago. And he looked at 3 sets of data. He looked at some autopsy data, looked at some SEER data, and then looked at a large prostatectomy cohort. And a couple of conclusions that his group came up with, which was very interesting, that if you look at men who died of other causes other than prostate cancer who had autopsies, the incidence of prostate cancer was about the same. And that's what we typically describe as low risk or latent prostate cancer. However, when you look at radical prostatectomy specimens, you find that men of African descent tend to have a more aggressive disease based on the volume as well as the Gleason grade, which was just talked about. But another point that I think is underemphasized when we talk about prostate cancer is the probability of being diagnosed with metastatic disease. African American men are 4 times more likely to be diagnosed with metastatic disease at diagnosis compared to men of European descent. And that's a very important issue, because even if it doesn't have that direct impact on survival. That is, even if those men go on to be treated with hormonal therapy or other palliative therapies and then succumb to other causes, having advanced prostate cancer is a very burdensome disease. There's a lot of suffering involved in both the actual diagnosis as well as the treatment of advanced prostate cancer. So that is a conversation that we often don't have about this disparity of prostate cancer between African American men and other ethnic groups. Next slide. This was some work that Oliver Sartor and myself and a few others did a few years ago working with Dendron, looking at a broad base of literature and trying to identify some of the risk factors that are associated with the health disparity in prostate cancer. Hit the button. And so as you can see, there are a multitude of factors related to socioeconomics, the biology of the disease, hereditary factors, and I won't go into that. We've touched on many of them already today. Next. You can actually hit it again. This was a study that Lucille Adams Campbell at Georgetown and myself and some others did a few years ago, looking at some of the barriers to recruiting African American men into clinical trials. And I think one of the prostate warriors in the audience brought that up. And one of our observations was that one of the top reasons why we were not getting our folks into clinical trials was comorbidities. So they were being excluded out of these trials because of the comorbidities. And I certainly understand the importance of design in terms of designing trials that can be implemented safely. But at the same time, if you have a particular ethnic group that may have a higher incidence of hypertension or diabetes or other comorbidities that may exclude them from these trials, well, then that may be an important barrier to getting the kind of recruitment numbers that we want. And so, again, incorporating folks who treat African American patients in the research design is an important part of addressing that issue. Next. This was a paper published in Cancer a few years ago, and you can hit that button about 3 times. And essentially, it talks about how to design studies that can identify the barriers to recruitment. And it divided it into different domains related to access, awareness, trust issues, and many others. And so I thought that this was a really good way of thinking about how do we now begin to systematically address the barriers associated with incorporating people into clinical trials. Next. One more time, I believe. Yeah, there we go. So this was some work that I did with Kate Taylor at Georgetown. Again, there's a lot of conversation now about shared decision-making, meaning that the provider and the patient sit down together and have this meaningful conversation and then come to a shared decision about what type of treatment to move forward after a diagnosis. You can also talk about that in the context of screening, sitting down and talking about, is screening right for me? And having the information and the expertise to support that shared decision-making process. Well, an important part of that is developing tools, educational tools that will help the patients make those informed decisions. And so that's one of the areas that we're focusing on at Howard University. Next slide. Next. There have been, I think, some successes in recruitment. And one of those is the work that's been done by Dendron Group, and I think they're one of the supporters of this program. Dendron developed an agent called Sipuleucel-T, or Provenge, which is an immunotherapy approach to treating advanced prostate cancer. And one of the studies that they did is a registration study where they tracked all the men who had received this new type of therapy and looked at a variety of factors, including their sociodemographics, their clinical characteristics, and also some immune factors as well. Next. And the objective of this particular study that we did was to try to get an idea of what were some of the differences between the African American group that was in this registry and other groups. Next. And one of the most glaring observations was that the baseline PSAs at diagnosis, or at the time they entered into these trials, was much higher in the African American group, suggesting that maybe African American men with advanced hormone refractory prostate cancer tended to have more disease burden at the time of diagnosis. However, next slide. That didn't necessarily pan out when we looked at other factors such as clinical stage, as well as disease-specific mortality. But what we did identify was that we were able, in this particular study, to recruit about 15% of African Americans in that cohort. And I think that that was a big success study for a large clinical trial of this nature. Next. So lastly, I wanted to talk about some work. This is work that's ongoing that I'm doing with Carrie Kildridge at the Dana-Farber Cancer Institute. And so we've talked a lot about some of the technical barriers to really addressing the issue of health disparity. When we talk of technical barriers, we talk about, what's the best treatment, robotics or brachytherapy or proton therapy. We talk about, making sure patients have insurance so they can actually get in to see the doctor. But there's this whole category of barriers, which I like to call, in fact, I coined it from Peter Provenos's description of quality improvement. He talks about adaptive challenges. This is more of the soft science. So things like health literacy and how do we make decisions about what type of treatment we want to get, and whether or not that process of making those decisions is actually impacting on disparity. So you often hear that African American men don't want to have surgery. They prefer to have non-surgical treatment. But when you actually start to look at the issues that may be driving that behavior or decision-making, it may be the kind of conversation that we're actually having with African American men. And so this is a study that's designed to really get a better understanding of literacy, health literacy that is culturally driven. So we have a number of tools that we're developing that will help us to understand better when you come in and have that conversation with your doctor, very similar to the question I brought up to one of the doctors that was diagnosed. Are we really empowering our patients to have that, to make that right decision? I mean, I know as a physician, I often hear patients say, well, doc, you're the doc, you make the decision. Is that really the patient trusting that I should make the decision for them? Or is that the patient deciding that, I can't make this decision because I don't have enough information, I can't process this? So almost deferring that decision to the physician or to the clinician. So trying to understand how much of that is a problem in the decision-making is what we're trying to do in this study. And all of that is soft science. A lot of that stuff has not been looked at, and it doesn't have the glare of some of the more exciting things that are happening technology-wise, but I think that it's really just as important in addressing some of the issues around disparity that we encounter in our practices as we treat patients with prostate cancer. Next. So I'll end, as I said, I would keep this as short as possible. I'll end by sharing a comment that I came across several years ago by a very prominent, at that time, prominent urologist. He was a pioneer in prostate cancer treatment. His name was David Culp, and he treated thousands of patients with prostate cancer back in the 20s and 30s, way before we were even really had a good understanding of what prostate cancer was all about. And he coined prostate cancer as the toothless lion. And, I've thought about this for years and years and years. What did he really mean by a toothless lion? Hit the next. Is a lion still lethal and dangerous without its teeth? Next. And I would argue that it certainly is. It has so many different tools that it uses, so many different resources that it uses to be dangerous and to be a predator. And then I thought, well, maybe Dr. Culp understood that. Maybe the issue with prostate cancer is that, not only do we underestimate it, but we overestimate it at the same time. And so that is the sort of the ubiquitous nature of prostate cancer. And I think that the answer is not going to lie in one lab or in one office or in one room. I think that the answer lies in building coalition that involves as many of the stakeholders that are involved in prostate cancer as possible. And I think that that's where the answers and the solutions lie in addressing the issue of health disparities. So once again, I want to thank you for inviting me, and enjoy your lunch.
We're going to take a couple of minutes just for a couple of questions, please.
That's one of the advantages to being the last speaker. Everybody's all burned out and we don't get any questions.
Oh, don't be so sure. So again, I'm Dr. Wingfield. Thank you so much for your comments. Very, very much appreciated, and very important for all of us, particularly in the Black community, to make sure we're advocating on behalf of ourselves and our communities about the importance of enrolling in clinical trials. There are two things that I wanted to make a comment on. You had mentioned the importance of understanding the social context with which we live, but you called it soft science. And I have a little bit of a problem with that because I think, as you mentioned, it's critically important. But if we continue to call the science of understanding social context soft science, we won't get the funding we need to do the very important work. As you know, the funding environment is weak. And it's really hard to get funding to do the type of work that we need to do in order to understanding some of that. So I just had that comment. The other thing I did want to mention also is that we have to work on workforce diversity. The reason why we're able to start this dialogue around the importance of understanding and defining what healthcare disparities are is because we have more practitioners and folks of color who are doing this research. And so you're at one of our HBCUs. It's really important, particularly in the field of oncology, where we only have 3% of the oncology workforce is Black. That's a problem in our growing community. So I want to see, number one, if you could just speak to this issue of workforce diversity. How do we kind of improve the ability of our communities to really engage in research, whether it be at the level of PhD, MD, or even with respect to making sure that we're involved in the research? Thank you.
Absolutely. Thank you so much. And let me qualify by saying that I probably shouldn't have used the word soft science, but I wanted to put it out there because I agree. I think that, you know, it's almost like a stigma, but it's such important work, especially when we talk about prostate cancer, health disparities, and health disparities in general. So thank you for that clarification. And in terms of workforce diversity, being at an HBCU that has a teaching hospital and a medical school, and so I would, you know, my insight, you know, being at Howard for about 20 years is that, you know, you have to start early. You have to begin to embed in the young folks who are coming into health sciences the importance of research and being part of the research enterprise. And, you know, a lot of times, again, it's one of those areas that sometimes, you know, not considered exciting or what have you, but you have to, as a educator in that environment, you have to emphasize the importance of, you know, lifelong learning, research design, and all of the other things that will continue to drive that. But it is a big challenge because we don't have enough minorities in research right now. Good point.